So it is a very interesting quote there from Erica Anderson, and talking about the difficulties and complexities involved in late adolescence and the different people's, I suppose, co-occurring issues is, for me, one of the big issues that I've noticed in my work as a psychotherapist. So I want to point out about gender dysphoria. And myself and Erin's presentations are kind of on similar subjects, but like kind of coming at it in a different way. I want to point out that gender dysphoria is a diagnosable mental health condition. It's the psychological distress that results from an incongruence with one's sex at birth and one's gender identity. And the DSM-5, which is the kind of the Bible of psychiatrists and psychs around the world, it provides one overarching diagnosis for gender dysphoria of children and specific criteria for adolescents and adults. So they've got one diagnosis for children and another for adolescents and adults. And that made sense really up until the last 10 years, because up until about 10 years ago, as we saw in Erin's presentation, you know, there really weren't very many adolescents at all. So it was pretty much, there was an adult's one and a child's one. And, you know, you were one or the other, and it never really caused any sort of major distress. Suddenly there's a new cohort. They've come in like a rocket. Anybody who's working in this field, working in the field of mental health, working in colleges, will know that this is an extraordinary number of adolescents are suddenly presenting. I do want to point out at the last point in that slide, it says, you know, the DSM-5, it's been around since around about the 50s or 60s. And every 13 or 15 or so years, there's a new edition. So DSM-1, DSM-2, DSM-3. And the DSM-4 revised, which came out in 2000, because some of them are DSM-4 and then DSM-4 revised, that used a different name for a same condition, which is gender identity disorder. The reason why I say that is sometimes people say, oh, gender dysphoria didn't exist before then. It's like, oh, it existed. It's just like schizophrenia or any other issues. And I'm not saying they're the same issues, but they underwent different name changes. And so that's all you need to be aware of. So bipolar also had different names. And it doesn't mean it's a different experience. It just means it had different names. I'm kind of very conscious that these days people don't seem to be madly aware that it is a mental health condition, that it is in the DSM-5, and that there are different criteria for children and for adolescents and adults. There's certain theories related to gender dysphoria. And lots of people, nobody knows really where anything comes from. You know, how does somebody develop any mental health condition, I suppose? You know, there's always theories. Sadly, at the moment, this is such a heightened field that these theories seem to be, it's very fraught to discuss the fact that there are different theories about how somebody might have gender dysphoria. The most current and most popular one at the moment, and the newest theory, would be the first one there, which is gender identity theory. And that means that gender dysphoria results as a result of the gender identity that's within us. This gender identity, we can't put our finger on it. It's a sense in your mind. It's unfalsifiable insofar as I can't tell you that it's very subjective. You might have it, I don't have it. We don't know. So certain people say that they have a gender identity, certain other people say that they don't. And who are we to disagree would be my argument there. And some people feel that sense of gender within them is causing them huge distress because of their body, their embodiment, their body. And so that's causing the distress. And that is why they have, gender dysphoria, and that's why they need to medicalize. So that's the concept of gender identity theory. Gender identity theory first came about because of Robert Stoller and the work of John Money in the 50s and the 60s. And they were very much absorbed in the world of DSDs, differences of sex disorder, also known as intersex. And they studied a lot of children, and they kind of decided that you could kind of almost socialize a child to become one sex or the other, depending on how you raise them. And they had an awful lot of experiments and an awful lot of ideas around our sense of identity. The work that they've done has been really discredited because there was a lot of tragedy around a lot of John Money's work, especially. And David Raymer is probably the most famous example of that. You can look it up yourself, but he was kind of socialized to be a girl because of some problems, complications with his surgery as a little baby when he was 10 months old. And it didn't go well. And he ended up in deep distress and sadly dying by suicide. So that's a kind of a tragedy. That was back then. That was 1950s, 1960s. And David Raymer was kind of, he grew up and, you know, he born in the 1960s and became a man in, let's say, the 1980s and stuff. But it's changed. Gender identity theory has changed quite a bit, but it remains as that's the root of where the theory came from. Then the developmental model of gender dysphoria, which is what I agree with, means that it results as it manifests as a result of distress, and the distress could be anything. And I would have a developmental model of most issues. Now, I don't disregard things like the biological model, which is underneath as a result of genetic factors. I think that's very interesting and certainly could be an issue. And also the biopsychosocial model, which could be a combination. It could be some socializing, could be some psychological distress, it could be some socialization, I should have said, or some biological input. And the combination creates gender dysphoria. My emphasis with this slide is we don't know. We do not know, we haven't a notion. And frankly, we don't know where alcoholism came from. We don't know where anorexia comes from. We don't know where lots of mental health distress comes from. We have our theories. I would like to live in a world where it's okay to have theories and where we could discuss it. And it wouldn't mean that it's a devastating consequence on somebody just to say, I have a different theory than you. May we discuss it and may we perhaps come to a better place where we can serve people better, because we kind of come with humility. And we come with an awareness that everybody's experience is subjective. I do want to point out that DSM, it particularly points out that sexual orientation is not the same as gender identity. It's a very different experience. As it says there, gender identity is different from sexual orientation. For example, pronouns, names, past personal histories do not need to be revised or changed if a person comes out as gay. Medical transition is not the same as coming out as gay. Being gay doesn't require active participation from family, friends, or society. It doesn't carry a heavy medical burden. And it's empirically tested and evident in the animal kingdom. There are gay or bisexual animals, and not only that, or lesbian, not only that, you can empirically test it. You can actually, you can test the fact that a person is aroused by another person. With their genitals or with their heart rate or their sweat or their whatever. There's a lot of different ways you can test it. There is no empirical test for gender identity. It's completely subjective, which makes it harder for us mental health professionals to work with, because we're in a much more nebulous territory, harder to kind of get our finger on what's going on. Very, very, very dependent on the ability of the person who's suffering it to communicate their distress. And that can put a lot of distress and kind of responsibility on the person who is suffering. Now, I know Aaron discussed the change in the cohort. Essentially, I have the same thing to say. It is quite interesting that historically there was two cohorts, young children and middle-aged males, and that was it. They were the big. And then suddenly, out of nowhere, it shot in the last 10 years, a very strong, high and intense number of people. They were very intense about their dysphoria, and it was adolescents, mostly females, but not only females. I know there's about, the latest study shows about 3% of college students who are boys, 3% of college boys are trans, and 5% of college girls. So while it's mostly female, the boys are catching up quite quickly. As it says there, that quote, the mix of young people presenting to the service is more complex than seen previously. This is a new cohort with new needs, and anybody who works in this field needs to be aware of those needs. Many of them have neurodiverse, have a wide range of psychosocial and mental health needs, and the largest group currently comprises of females first presenting in adolescence with gender-related distress. They never came, there is no long-term medical literature on this cohort because they were never there. The numbers were vanishingly small, and so they were never there, so they weren't studied. So any work you're doing with either adolescents or young people, around gender, there isn't a long-term evidence base supporting your work. And that makes it frightening. And it makes it more important than ever that we proceed cautiously and we make sure that we remember the foundational principle to first do no harm. You can see with the graph there, you know, and Erin showed it as well. I want to point out the differences between childhood onset gender dysphoria, and I had childhood onset gender dysphoria. I won't bore you with my own story, but I did have it and it was very intense. And I had it for years. But the criteria here is, I find that the criteria is very stereotype laden and it's quite regressive. When we read it, you'll see what I mean. But you have to have six of these traits. There's 8 of them in total, and you have to have them for at least 6 months. I had all 8, and I say I had them for about 8 years. So I had certainly a very intense experience as a child. So the first one is a strong desire to be of the other gender, or an insistence that one is the other gender. Now, between 2 and 6, I bolded because my emphasis is I put it in bold writing. The reason why I did that is because it's so regressive, frankly, and it's so stereotypical. So number 2 is a strong preference for wearing clothes typical of the opposite gender. You see where Mike is going. A strong preference for cross-gender roles and make-believe play or fantasy play from the other gender. Strong preference for the toys, games, or activities stereotypically used or engaged in by the other gender. Strong preference for playmates of the other gender. A strong rejection of toys, games, and activities typical of one's assigned gender. To me, this is something from literally another century. This is old-fashioned. The idea that there's clothes belonging to any, like whether it's a girl or a boy and they're 8 years old and they want one clothes over another. I would like to live in a world where little boys could run around in fairy dresses, waving their magic wand, and nobody tries to categorize them or evaluate them or assess them for anything other than a happy little kid running around, you know? And the very same for a little girl, that she could take out her sword or her saber and kind of play with complete unself-consciousness. To me, that would be a freer way to approach any child. And to put that into kind of criteria seems to me very old-fashioned, if I'm honest. Then 7 or 8 seem more serious. A strong dislike of one's sexual anatomy. And number 8, a strong desire for the physical sex characteristics that match your experienced gender. So the thing is, you have to have 6 out of 8 of those criteria, and you have to have them for at least 6 months. Like I say, I had them for many years. Adolescent onset gender dysphoria has arrived like a bullet. I've taken these figures from the UK because this is the biggest gender clinic in the world. It's called GIDS. And also because there isn't centralized stats from the US or Canada. And so I wanted to get kind of reliable governmental stats. So there's been a 2000% rise in adolescence in the last decade. And I would say it's very similar in the US and Canada. I think anybody who works in the field would agree that it is. And there's been a 5,337% rise in the number of females. Like I say, more females, but the boys are quite quickly coming on with gender dysphoria. I want anybody who's working in this field or who's working with colleges to realize that childhood gender dysphoria presents very differently than adolescent gender dysphoria. Childhood gender dysphoria, it arrives between about 3 and 6 years old. For me, it was about 3 years old. It can be, but not necessarily, an environmental response. For example, maybe you're not allowed to play with boys' toys, or maybe you're a little boy and you're not allowed to wear a dress. It's very clear. When a child has childhood onset gender dysphoria, everybody knows. It's not a secret. The whole town knows about it. They make it they get it as a child, and they're completely unself-conscious, and they're very loud about it. And they're very clear, I'm the opposite. So I was like a boy, and everybody who knew me knew I was a boy. So there's no intervention necessary unless there's other issues causing deep distress by the child. And very often, 70% of these children turn out to be gay, lesbian, or bisexual. So you'd have to be conscious of the concept of maybe they might be pre-gay, as we often call it. In adolescence, it's very different. That could be anything between 9 and 20, 22. You know, an awful lot of children these days are really quite immature, or certainly not mature compared to my own generation. And so it can present quite late. And even if they say they've always felt uncomfortable, that's still not childhood onset. Childhood onset, everybody knew about it. It came loud between 3 and 6 years old. So it's adolescent onset if they're talking about it in retrospect, but they don't start talking about it until they're 14 or 12 or 20. It's often an environmental response following trauma. I know some of the studies have showed it's very often after some sort of distress, and often very secretive immediately. Huge likelihood of comorbidities. The study that Aaron commented on said that there was 63% of the children in the ROGD study in 2018 had other diagnoses, and mostly ASD. And it's quite noticeable with the Tavistock, and it's the largest, like I say, the largest gender identity clinic in the world. 48% of the children presenting there have ASD, autism spectrum disorder. Huge comorbidity issue around adolescent onset. And so anybody who's working with these children need to be aware, or adolescents or young people, need to be aware that if it's adolescent onset, watch out for comorbidities, because you won't be looking after the student in front of you if you've missed the comorbidities. And often it can be a result of internalized or externalized homophobia. Some people really don't want to be gay, lesbian, or bisexual, and you'd never know it because they hide it. And some people are very driven, but like they say, I'm not a lesbian, I'm a man, and that's why I fancy girls. And they're driven by either internalized or frankly externalized homophobia. As a psychotherapist, I released a book there recently about bullying, and I find so often so much bullying is around homophobia. I think for all our waving of our rainbow flags, we really don't seem to have got a grip on homophobia in schools at all. Like, it's shocking to be honest, how much there is bullying around homophobia. It's unbelievable sometimes. Some common features among gender dysphoric young people: they're very often intelligent. These are the young people, the adolescents. There isn't really as many common features of the childhood, because a lot of them are frankly gay and they're just gender non-conforming kids. There isn't common themes in these kids. There's a massive golden thread with the gender dysphoric adolescents. They're very much a type. And I'm going to describe this type, and I have no doubt many of you are going to recognize that type, and you're going to think, that's like the student I'm working with. They're intelligent, quirky, socially awkward, sensitive, often very naive and vulnerable, hyper vigilant about their gender dysphoria, filled with certainty, which I want to point out is not an indication of good mental health. The human condition is to be unsure, and to be filled with certainty doesn't mean that that is what they should do. It means that they've lost their sense of their reason around something. We should be unsure because we're human. They often have an online self-diagnosis. It's very often socially mediated through online behavior. They can be very compliant, very obedient types, very likable and sweet. And they often have comorbidities, but the big one is autism spectrum disorder, ADHD, OCD, eating disorders, and anxiety. You're going to see that all the time with these youth. So they're very, very vulnerable, and you need to be very, very gentle with them, and very, very slow and cautious with them. They might be filled with hurry and urgency. That's not anybody who works in mental health knows you don't necessarily go at the speed that the person wants to go at. Your job is to hold the space in the room and to bring in gentleness, bring in soften the kind of intensity, so that they can come from a place that is kind of more in touch with their prefrontal cortex, rather than being driven by an emotional certainty, because that can lead to a lot of distress. I want to say as well, I point out about the difference between the emerging adult and the fully functioning adult. The emerging adult, Jeffrey Arnett brought this. I thought he was brilliant when he did a study on this in 1995, and he talked about the in-between adult. And it's usually, well, back then they were talking about between 18 and 25, but then Friends came in around about then, and it's it's extended it's now 18 to 30 and beyond. And Friends are, the TV program, are a very good reflection of the emerging adult. They have very different focus than the fully functioning mature adult. And there's a world of difference. So there's these days, it used to be child adult. And then in the 20th century, it was child adolescent adult. And, adolescent was coined in something like 1913 by Stanley Hall, or used more regularly. And so there was child adolescent adult. And then they've moved it on in the last few years. And now it's like child, tween, adolescent, emerging adult. And so there's many more stages, and the emerging adult can sometimes feel at sea. So if we look at the kind of focus of concern for the emerging adult in this table, you'll see they're seeking identity. That's what they should be doing. They're an emerging adult. They haven't quite found themselves, like I say, between the ages of 18 and 25, in and around. They're generally very unstable lives, and so they should be. They're enjoying themselves. Very unstable in their work, in their love life, in where they live. They might be living here. I might go and live in the country. I might go and live in the city. They're charging around the world, and so they should be, because they're in that space. And then, like I say, this can continue up for me. It continued till I was about 30. They're focused on self-development, very much focused on the self. Who am I? What am I about? What do I like? Who are my friends? They feel in between. They don't feel like adults. They feel in between. And they optimistically believe in very large and possible life pathways. While the fully functioning adult, the mature adult, is in a very different space. They're accepting their responsibilities, as you see there. They're making independent decisions, and they're financially independent. So they're doing their own thing. I think it's important we need to be aware that there is a big difference between the 18-year-old, the 19-year-old, and the functioning adult who knows what he's about and is paying his own way. So 3 treatment options for gender dysphoria. The person's sense of gender can become aligned with their body. So their mind can change to become aligned with their body, or else their body can change to become aligned with their mind. So you might change your mind to become aligned with your body. You can change your body to become aligned with your mind. Or else the third option, which I think helps every single person who's in front of you, is you help them with a range of approaches to help with their distress. And that could be emotional regulation, behavioral management, distress tolerance, all the things that any mental health professional, and I know there's a lot of you here in this seminar, they can always, that's a gift to every single person who's in front of you. Can you help them manage their distress? Because you can take that with you for life. After that, they can make the decision whether they should let their mind change to become aligned with their body, or let their body change to become aligned with their mind. I think that's up to the individual. Past approaches, Aaron commented on them. Watchful waiting was back in the day, allow some time to pass before medical intervention. That's a concept that's used all over hospitals all the time. If I came in with a sore arm and the doctor wasn't sure what to do, they'd say watchful waiting. Let's just watch this and see what way we should go before we jump in with interventions. Because the least invasive first procedure, or the least invasive first approach, is acknowledged to be probably the most helpful approach a person can take. I don't want to take much of your time because we've got some brilliant talkers on the way, so I'll skip through this a little bit quickly. Gender identity affirmation, that is in the last 10, 15 years, as Aaron said. There's no long-term evidence base for it. It's a new kid in town. It basically encourages the child or the adult or the adolescent or the young person to live in the gender that they feel comfortable right now. And if they want medical intervention, they should get it right now. And it doesn't really have much interest in the future because it's all about the here and now. And so if somebody wants to be, if a 16-year-old wants to be, a 16-year-old girl wants to be a 16-year-old boy, they should immediately medicalize and become that 16-year-old boy with very little thought or reflection on whether they want to be a 36-year-old man or whether they want to be a 46-year-old man. That's kind of not part of the gender affirmation approach. The gender affirmative approach is in the here and now. Well, the gender exploratory approach, which is one that I take myself, is explore the person's or the adolescent's or the child's understanding of gender roles and their explore around their kind of self-acceptance. There's lots of ways to approach anybody's distress. And I think it's very important that we give some space to all the different ways that we do approach it. I know people worry about issues such as conversion therapy, but conversion therapy was a dreadful practice, a horrible and brutal practice that was mostly kind of, let's say, 50s, 60s, 70s, and well, before that as well, but it wasn't therapy. It was frankly terrible, brutal practices. And I don't think it should ever be called therapy. Conversion practices are terrible, and no ethical therapist would ever carry out any sort of conversion of a client. It's just not what ethical people do. What we do instead is we explore and we kind of help the person in front of us see where they're coming from. I want to talk a little bit about suicidality. There is very little peer-reviewed evidence about suicidality. We've got 1 or 2 pieces of information that do give us some information. I know you can look up stats for gender if you want to know further information, just basic peer-reviewed stats about gender. It's great, statsforgender.org. And this quote from the Tavistock is probably, like I say, the biggest gender clinic in the world. From 2010 to 2020, so in 10 years, 4 patients were known or expected to, let me get this quote right, to have died by suicide. So 4 out of 15,000 patients, including those on the waiting list. So that was the kind of the 10 years between 2010 and 2020, when there was a big shoot in the numbers, big uptick in the numbers. And the risk of suicide among gender dysphoric youth seems to be similar to the risk of suicide among other people with mental health challenges, for example, anxiety, OCD, or depression. If you are seeing somebody who's already medically transitioned, you need to be aware that the only long-term study on that shows what is their suicide rate compared to the general population is they're 19 times more likely to die by suicide compared to the general population. Now, they do have a condition, which is gender dysphoria. It's very difficult, but you need to be aware that just because they've medically transitioned does not make them less vulnerable. And if you're working with somebody who's medically transitioned, you need to be very alive to that fact. This is an interesting study. I think it's very helpful for anybody who is interested in suicidality. It was taken in Sweden by the health authorities. What they did was study suicidality, people who actually died. It's a frightening subject. Every suicide is a tragedy, but we need to grapple with it when we work with mental health, and we need to make sure that we know the facts. And we need to make sure that we're talking with responsibility and with authority, because we know the facts. And these facts, to me, are probably the most helpful. What they did was just compare and contrast the suicide mortality of different mental health conditions. For example, personality disorder scored highest, schizophrenia scored high, harmful use, addiction, dependency, that scored high, then bipolar, and then depression, gender dysphoria, and autism were down in the more, along with anxiety and things like that. Just so you know, you can see there's a huge spike in women. Usually women don't die by suicide in the numbers that men do. And I would argue the reason for that spike would be perhaps the input of testosterone into a female body, because they often talk about they become more aggressive to themselves, more impulsive, more reckless. And to me, it explains it. It's only a theory. I might be wrong, but I think it's very important that we really look at these stats and know what we're talking about. So I want to finish up by pointing out the mental health professional who's working with gender dysphoria, they need to be empathetic, compassionate, patient, respectful of the person's defenses, and be aware that they have defenses and they need those defenses. Sensitive to any risk of social contagion, which is a big issue in gender dysphoria, and aware of the relapse cycle. If you can be aware of all those issues, you probably, sorry, I just stopped sharing now, you'll probably have a good, do service to the person who is in front of you.